only the knife surgeons.
Thank you very much.
Thank you very much, sir.
I would like to add one more point to what Sir said. Instead of random Google searches, it would be good if the necessary tech or whatever websites are there shared with the patients rather than somebody else sharing.
Can I just
Sorry, thank you.
Can I just add end note?
Yeah. One sentence.
2 sentences.
Yeah, go ahead.
So, first of all, I think today we should definitely remember this day because this is the first time where doctors took the appointment of patients. It is always the other side. We wait for the appointment of the doctor. So Dr. Sanjay called us. Are you okay? Are you free? 4 o'clock, so and so day. So please come. So thank you so much for taking our appointment. So I think we will definitely remember this day. And secondly, I know I have raised one point that post treatment, which we were discussing also, that now I'm running a small company, which is into health sector, which I need the support of the doctors, which have been even support of in terms of content, support of even in terms of some kind of crowdfunding, which I'm looking at. I'm going to recruit only cancer survivors in my company, which have been talking to Dr. Sanjay. So please, I don't know how to connect with you after this meeting. I would probably take the help of Amit sir and Sanjay sir. I'm going to build a 100 crore company, which is going to be a health sector in next 5 years. So I need the support. So please do something for it. Even if you all contribute 2 lakhs, that is what I need. Crowdfunding kind of a thing. And ultimately, at the end of that, it is a business. I will make you 2 lakhs, 1 crore in 5 years.
Thank you.
So, sir, we need to conclude
very valid,
now.
very interesting point. There's one thing you can do on Monday morning. Don't have a second patient and a caregiver in the room when you're already attending to a patient. Patient loses dignity. Patient can't explain everything he wants to or she wants to in the presence of others. Only one patient at a time, please. Thank you.
Thank you.
Thank you very much, Dr. Sanjay Adla, for this excellent session. I thank all the panelists for sparing this valuable time. Our next session is a sponsored session. Our next session is a AstraZeneca sponsored session, ADT with salvage RT for prostate cancer. How do we hit the sweet spot? And we have Dr. Alison Tree speaking about it.
Thank you very much. Quite hard to follow that session, so congratulations to the organisers. I think that was amazing. So my more mundane task is to talk to you about the duration of hormone therapy in the setting of post-operative radiotherapy. Here are my conflicts of interest. So I'm going to confine this discussion to the salvage setting. And as Rahul explained earlier, this is because of the Radicals RT trial, which many of you will be aware of, run by my lovely colleague, Professor Chris Parker from the Royal Marsden. So this was a trial about when we irradiate in the post-operative setting. And he recruited, or the trial recruited, men who'd had a radical prostatectomy, who had a low post-op PSA, and then at least one high-risk feature, so T3, T4, Gleason 7 or above, pre-op PSA of 10 or positive margins. And these men were randomized 1-to-1 between adjuvant radiotherapy, so immediate post-operative prostate bed radiotherapy, versus salvage radiotherapy at the time of PSA failure, using a low threshold of either 3 consecutive rises or 2 rises in PSA with the second one above 0.1. And this was published in the Lancet in 2020, as many of you will know. And as was mentioned earlier, on the left-hand graph, you see what happened to the men randomized to salvage radiotherapy. So the majority of them, 68%, never needed radiotherapy. So in other words, they'd had a prostatectomy, they had at least one high-risk feature, but they never failed within the median follow-up of about 5 years at this point. And on the right-hand side, obviously, the adjuvant patients all got their nearly all got their radiotherapy. But the bottom line from the trial was that in terms of biochemical relapse-free survival, it made no difference. So essentially, you lost nothing by waiting until the PSA failed. And so this was practice changing for many of us. So no longer do we use adjuvant radiotherapy in the UK. We wait, monitor the PSA carefully, and irradiate the prostate bed only if and when the PSA rises, thereby sparing those men unnecessary radiotherapy. So when we do have to irradiate the prostate beds, the PSA goes up after this operation, and we decide it's time to give prostate bed radiotherapy. When do we give androgen deprivation therapy in addition? We know ADT comes with side effects, so we want to minimize the use of it where possible. So I'm going to focus on just 2 trials. The first one is the SPORT trial, which is an American trial, RTOG 0534. And this was a 3-arm trial, so for men with PSA failure after prostatectomy, randomized between prostate bed radiotherapy alone versus the same radiotherapy with a short course of hormones versus the same radiotherapy with a short course of hormones and pelvic lymph node irradiation. So 3 different arms, large trial. And the median follow-up at the time of presentation and publication was over 8 years. Just a couple of things to highlight. So in this setting, in the States, the majority of men had a pelvic lymphadenectomy, which is different to our practice in the UK in general. And the median PSA was relatively high, so higher than we would normally treat, certainly in the UK, where we aim to treat well before the PSA hits 0.2. So this was a more unfavourable population in terms of risk factors, and only a minority had the low PSAs. But what the trial showed in essence was that the addition of hormone therapy improves progression-free survival. That's the curves on the left. So the red one is prostate bed alone. The blue one is prostate bed radiotherapy with short-term hormones. And the green line is the patients who also received radiotherapy to the pelvic lymph nodes. So you can see they did the best of all. And that in general translated to a metastasis-free survival advantage, which was just about significant between the 2 groups. However, if you looked at the patients who had the lowest PSAs, they didn't seem to have any additional benefit of the pelvic lymph node irradiation. So clearly there's a spectrum of patients and prostate cancer biology going on here. So moving on to the Radicals trial. So this was a large and turned out to be quite complicated trial. So it set out to determine who needed no hormone therapy along with their radiotherapy, who needed 6 months, and who needed 3 years. And that's the bit in the middle there, the 3-way randomization. But unfortunately, we as doctors are not perfect. We have preconceived ideas. And what they found was that doctors were often not happy to randomize through such a wide spectrum of 0 hormones to 2 years. And so they allowed a sort of compromise, which ended up being most of the trial. So most of the patients in this trial either randomized between no hormones and 6 months of hormones, or 6 months and 2 years of hormone therapy. And what they did when they analyzed was that they pooled the groups. So essentially, you've got 2 trials, no hormones versus 6 months, and short course hormones of 6 months versus 2 years. And first of all, I'm going to focus on this first randomization here, no hormones versus short. So first of all, the patient characteristics, because this is important to how we interpret this rather perplexing result. So first of all, the PSAs were quite low, on average 0.2. Only a minority of patients had T3B or T4 disease, so generally quite localized disease, and only a minority had Gleason 8 or above, so a favourable cohort after their surgery. And most of the patients had LHRH analogues as their hormones of choice. A minority had bicalutamide as monotherapy. And very small numbers in this group had pelvic lymph node irradiation. So this is the most important result from this first part of the trial. So this is metastasis-free survival in these men the graphs plotted out to 10 years. Median follow-up was about 10 years at the same time. So the hazard ratio for metastasis-free survival, 0.89, but crosses 1. So in other words, no significant effect on your chance of being free of metastasis, whether you had hormones or didn't have hormones. Now, time to salvage hormone therapy was different. But however, this means that you're using short-term hormones to prevent short-term hormones later. And so that wasn't deemed a very important clinical endpoint from the point of view of the study, because we know that hormone therapy drops PSA, so it's not surprising that it dropped PSA. And of course, no difference in overall survival. Most of these men are cured of their cancer in the end after their treatment, which is great. So then moving on to the second half of the trial, 6 months versus 2 years of hormone therapy. In this group, because they were physician selected, they went into the higher risk group and all got some hormones. They had the same PSA, but slightly worse features otherwise. So more T3B, T4, more Gleason 8 to 10, and more of them, although still a minority, got their pelvic lymph nodes irradiated at the same time. In this group, there was a significant improvement in metastasis-free survival with 2 years hormones versus 6 months alone, with a hazard ratio of 0.77 and an absolute benefit of 6% at 10 years. So the event-free survival went from 72% up to 78%, which I would say is clinically meaningful. Same result as before. If you use hormones, you delay the time to PSA failure, which is perhaps not surprising and not practice changing on its own. And once again, overall survival very good in this cohort, and we're not expecting there to be an overall survival advantage that appears after 10 years. So in terms of the Radicals trial, what the conclusions of the study investigators was when added to post-operative radiotherapy for prostate cancer, long-course ADT compared with short-course ADT improves metastasis-free survival, but short-course ADT compared to no ADT did not meaningfully improve metastasis-free survival. And of course, from the SPORT trial, we've only got very short follow-up, so we won't know whether that will really play out in the longer term either. And I haven't shown you all the forest plots, but eventually these conclusions are robust across all the different parameters like Gleason and T-stage. So what does that mean? How do we interpret that in our daily practice, day to day? So that it's clear that some men don't benefit significantly from the addition of ADT alongside salvage radiotherapy. But some men do have a significant metastasis-free survival benefit with 2 years of androgen deprivation. And the distinction between those two groups is not very clear because of the design of how Radicals played out. So what do I do pragmatically? Because we have to make a decision for the patient in front of us today. So if the patient has been referred back to me with a higher PSA, so 0.3 or above would be high in our practice, and or they had locally advanced disease at prostatectomy, and or they were Gleason 8 or above, then I generally recommend 2 years of hormone therapy. If their PSA is low and the kinetics are fairly flat, if they've had a late relapse many years after prostatectomy, no high-risk features, then I would recommend no ADT at all. And there's unfortunately a grey area in the middle with patients in between those two groups where we're not really sure. The evidence is not yet conclusive about what we should do. So obviously what we would do, just in light of the last session, was had a conversation with the man in front of you about his priorities. We are awaiting a further analysis called DAD Sport, which will bring together Radicals and the other relevant trials like RTOG 9601, which may help to define that group in the middle and who we should treat and who we should not. And that's the end. Thank you very much.
Thank you so much, Alison. We almost, all of us, use PSMA PETs post-op. Whatever, I mean, 0.2, 0.3, 0.8, we do PET scans. I don't know whether you do it or not in practice, but they were not done in either of these trials you showed us.
Correct.
So what do we do?
Yes, good question. So in the UK, it's not uniform. So we are lucky to have access to PSMA at the Royal Marsden, but not every centre in the UK does. And we would routinely scan if the PSA is above 0.25 or something like that, where the sensitivity starts to go up. But you're right, the patients that really benefit might be those where we would have picked something up on PSMA, and we don't have that data. So at the moment, we don't really, if we find a metastasis on the PSMA, obviously that takes us down a different tract. But if the PSMA is negative, I would carry on.
So again, this whole story of Will Rogers is going to come in. And will Radicals HD and Sport become irrelevant when you adopt PSMA and Americans adopt PSMA as normal?
I don't think they'll become irrelevant because they're never going to be done again. You know, Chris Parker started this trial 2 decades ago. No one's going to repeat it in the PSMA era. So I think we have to live with the limitations of the evidence we have. And I think there is a group, we know from the radical prostatectomy, there are some that are higher risk. Those ones I would still give 2 years of hormones to, even if the PSMA is negative. That's just my personal feeling.
Okay. And would there be a group of patients that, say early 0.3, 0.4, 0.5 PET negative, where you would not do the ADT and do the pelvis instead? The arm the sport didn't have.
The arm,
PET
yeah.
and pelvis.
Only if I was, I probably wouldn't, but I wouldn't risk it because I think there's a high chance they will fail somewhere else. You'd have to be very, very sure it's going to be a pelvic lymph node failure, which is the next most statistical place after the prostate bed. Does that make sense?
And what if a lymph node dissection was not done?
So none of our patients have lymph node dissections routinely, so almost none.
Right,
Yeah. So that changes the failure patterns, yeah. And that was the same in the radicals trial, so very few of them had a pelvic lymph node dissection. It's not routinely practiced in the UK.
Even for higher risk patients?
Yes, even for higher risk.
Oh.
But there's, yeah, small proportion.
Okay, thank you.
Hi. I can't quite
Can
hear
you please put on the mic of this audience mic?
Yeah.
So you can go ahead meanwhile with your question.
I think he's reached.
Okay.
I just wanted to tell Vedant that we have a lot more high-risk disease, and lymphadenectomy is done by most of us, which is a very different practice compared to the UK practice. That's one thing. And secondly, what matters is the micrometastatic disease, which is going to cause failure, both in the local and the node complexes and distal as well. So ADT becomes a very key component of the treatment plan. So whenever you have a high-risk disease, to design a trial just purely only on the local treatment might not be very wise. Am I right?
Yeah, no, I agree.
Yeah. So I think that since you didn't randomize clearly into the 3 groups, this actually lends, I believe you could, devise a nomogram.
Yeah.
Based on the other pathological features to see the benefit of short-term and longer-term hormonal therapy, because it's all done as a part of an otherwise controlled randomized trial.
Yeah. Yes.
Yeah. So maybe that nomogram will help us decide who needs the ADT at all.
Yeah. No, I agree. Yeah.
If you are doing a PSMA PET scan, if there is 1 node or 2 nodes positive, will you be